This morning we have 4 speakers. We have Leslie Smith, who is a patient's daughter, Carol Ward, who will join us remotely, Christina Kraus, and then Andrea Feltzman. Each speaker will come up in order and do their presentation, and we'll have, as we have had before, questions at the end.
Hello, my name is Leslie Smith. I'm not a public speaker, so I will do my best. I am here to represent my mother and also to represent patients. I am the daughter of a member who was admitted to hospital. Sorry. Yeah. Can you hear me now?
Yes,
okay, thank you. So this is my mother. This was 3 weeks prior to her being admitted to the hospital. She was admitted because she had back pain. She had compressed discs and osteoporosis. She was on a slow-release morphine before she was admitted to the hospital that she had received from her doctor a few weeks before her admittance. My mother had a functioning life when she entered the hospital. She went out daily for lunch and dinner to visit friends. She went to Tim Hortons at 9 o'clock at night. In the last 2 weeks before entering the hospital, though, she did have some limitations. Her back was bothering her because of too much social activity. She lived on the island. She had a dinner in Ladysmith on Friday night. She had a luncheon the next day in Parksville, and that evening she had another dinner in Qualicum. I was exhausted when she told me that's what she was going to be doing for the weekend. And so, just as expected, that was a cause for her to have re-injured her back. It was getting in and out of the car, sitting in bad seats, and even though she went to the doctor and had some pain medication given to her, she was admitted into the hospital. The purpose for that was for her to go to the pain clinic and get a cortisone injection in her back, and that had relieved her pain previously, so we expected that this would have the same result. When she was admitted into the hospital, she was living at home. She was walking with a walker with no difficulty. She was calling and speaking to family members on the phone with no assistance. She'd call me at 10:30 at night when she got home from Tim Hortons and tuck me into bed. She'd talk to my husband. She instigated the conversation. She was eating 3 meals a day and had a healthy appetite. She weighed 129 pounds, and she was sleeping from 11 o'clock at night till 6 in the morning without any need of any sleeping medication. She had been diagnosed with dementia, but she had a fully active life. She just went on day to day with her things, and she adjusted with some of the limitations she had. When she entered in the hospital, she was given Haldol sometime. We think it was December 25th, 3 days after she was admitted, and we actually I'm still trying to find out why she was given Haldol. She began eating meals sporadically. She was walking with her walker, but she was altered, and we thought this was due to the pain medication that she was given. We did not know that she was on Haldol, and she wasn't herself, but again, we were attributing that to the pain medication. On January 3rd, she received the spinal injection, and it seemed to relieve the pain. She was eating meals sporadically, but she was becoming very agitated, and they moved her down to transitions after. And I found her strapped into a wheelchair there. She repeatedly was asking me to untie her. She was walking with a walker. Her speech became compromised. She was sort of mumbling her words, and she was having difficulty communicating. She kept asking me to help her. Later, they had said that it was delirium that she was suffering from, but she just seemed to be declining, and we couldn't figure out why. I live in Vancouver. She lives on Vancouver Island, so I was going back and forth on weekends. I went back from January 11th to the 15th. She was hardly able to speak. She was slapping and pounding the chair. She was taking her clothes off. She was taking her shirt off. She wasn't eating, and she was still on Haldol 3 times a day. And again, we still didn't know what was going on. On January 15th, I arrived, and she had just, we just couldn't believe it. She was agitated, flailing around. Her left eye was closing. Her joints were stiff, and I said to the nurse, "What is going on?" the nurse said, it's the antipsychotic drug. And I said, what antipsychotic drug? And he said, well, it's the Haldol. So he said, I've called the doctor and I've told him to come. So the doctor came. He took one look at her, and I could tell when he looked at her he was horrified. And he immediately took her off it. He said that she should improve in the next few days and that the drug would wear off. So that's what we expected would happen. I looked into Haldol, and I phoned Harvard Medical School, I phoned the Mayo Clinic, I phoned doctors who were in the British Journal of Medicine, I phoned everywhere to find out about it. And I phoned the office of Dr. Lewis Kaplan. He's a professor of neurology at Harvard Medical School, and he's the senior neurologist at Beth Israel Deaconess East Medical Center. And I spoke with his office and his assistant. She told me immediately to get my mother to see a neurologist because, in her opinion, she felt that the Haldol had done harm to her, and she referred me to the Alliance for Human Research Protection, which is where I've got this information. So, according to Dr. Kaplan, he said that Haldol was the most overused drug among patients hospitalized on medical and surgical services and intensive care units. That one dose of Haldol can be disastrous for patients with Parkinson's and extrapyramidal conditions. And when the sedative effects of Haldol wear off, patients naturally often have a rebound hyperactivity. Any sedated individual can become temporarily restless when they're becoming more alert, and unfortunately they're often knocked down with more Haldol rather than letting the natural course of recovery from sedation transpire. And my experience with my mother was that she was extremely agitated. This was nothing that we had ever witnessed. And she had lost her speech, she had lost her ability to speak, and we just couldn't figure out what was happening to her. I had gone home for a couple days. At this time, the doctor had said that in 3 or 4 days she would recover and that the drug would come out of her system. Well, I got a phone call saying she was being transferred up to the acute ward. So I immediately came back over. She was transferred to the acute ward. At that time, the staff didn't have any history on her. They assumed that she had come in from a home. I said no, she was down in transitions. When she entered the hospital, she had come from her home. She was a functioning human being, that she had been walking. They just looked at her like she had come in from an assisted living place, and they made assumptions that weren't correct. I found her tied into the bed. She was screaming, and this is the first time her screaming was continuous, that she was screaming all the time. There's just a marked decline from when she was there on the 11th, and she was slapping herself and just thrashing around in the bed. So I immediately asked them to untie her and take the belt off, to which she just went, quieted down, and laid in the back of the bed. From January 25th to February 2nd, she was off all of the drugs. We'd had her taken off everything. She was off Haldol, she was off morphine, and she started to have some progress at this time. She started eating meals, she was walking assisted, she was toileting, she was more responsive. She was responding to yes and no and saying some sentences were being blurted out. She did start to brighten up. Her slapping was 90% gone, it was almost gone. She was drinking from a cup on her own. That seemed like a marked improvement, but prior to her being in the hospital, she was doing all of this at home anyway. She was still screaming, agitated, and she kept saying, "I'm so frustrated, please clear my brain." She was given trazodone for sleep because her sleep was off then. She didn't used to go to bed until 11 or 11:30 at night. Well, they put her to bed at 8 o'clock, so surely she was up at 2 o'clock in the morning. She'd already had her sleep. She was brightening up still until this time. And then February 6th, she had a 24-hour care worker. She fell out of bed while she was under supervision with the care worker. I arrived the next morning to find her strapped into a chair. She was tied in with bed sheets to a chair, and I don't know how long she'd been there like that, but she just looked absolutely deflated. And that was the next day after she had said, "I'm better today," and she was better that day. On February 8th, she had a really bad night, and she was screaming and yelling all night. They stuck her in a Broda chair and stuck her at the nursing station all night. And I arrived the next morning. They said that she'd had a complete meltdown. Well, the reason for that, luckily there were 2 nurses who knew my mom, and they discovered that she had severely impacted bowels, and that would most likely have been the source for her being extremely agitated and screaming the night before. But then the doctors were concerned again about her banging and agitation that hadn't stopped. The doctor on call said he consulted with the on-call psychiatrist, and his explanation was that her brain is attached to the Haldol-type drug. She requires another drug to bring her out, and like a heroin addict being taken off heroin cold turkey, which is what happened to her, Haldol should have been weaned off, and that Nazanan would hopefully do that. We were desperate for her to improve and to help her, and so we agreed to do that. Though when the morphine wore off, she was screaming, and during the time when she was given the morphine and the Nazanan, to begin with, the doses were too high, and she was snowed under for 2 days and never came to. February 11th to 28th, she was still taking the Nazanan. She was having difficulty eating without assistance. She was randomly eating meals. Now she wasn't walking as much. The walking team, they didn't have very many people, so they sort of, she was a little bit more difficult, so they passed over her and went to someone else who was easier. She at this time also was overdosed on morphine or Dilaudid. I'm sorry about the medication. I'm not quite sure, one of the two. And then they had to use Narcan to reverse it, so they had to bring her out of her overdose. When she was able to speak, she said, "Why don't you people pay attention?" And then she said, "I want to say one thing. I want to go home." The week of February 27th, she didn't have a care worker for one of the shifts. She was put in the hallway in a chair. She'd taken off her shirt, so she was sitting in the hallway naked with her shirt on. She hadn't eaten breakfast because there was no one to feed her. During this whole time, the staffing issues were horrendous. We couldn't get staff. I was there. I came as much as I could from Vancouver, and then I just stayed on February 24th. I never went back home. I stayed with her. But I still, every single day, went in and had to argue with nurses, had to argue with doctors, had to review the care plan every single day because there was a new nurse or a new doctor every day. Even though there was a care plan, nobody was looking at the care plan, so I had to retrain them on the care plan every day. On February 28th, I finally got fed up and I hired the nurse next door. I hired them for the hours between 8 and 10, 12 to 2, and 4 to 6, and the objective was to feed her, toilet her, and walk her. Those were the 3 things that my mother needed to have done and that was not being able to be done in the hospital setting. Sometime during March, my mom said, "I'm not crazy." And I said, "I know, Mom, I know you're not crazy." She was still agitated, but due to her inability to communicate, it wasn't clear whether she was in pain or frustration. She did have pain for her back, I know that, but I know she was extremely frustrated, and that, I think, was the source of the majority of the agitation. They were asking her if she wanted to have a drink. Do you want orange juice? Do you want ginger ale? What is it that you want to drink? They kept asking her, and she was getting frustrated. She just went, and just gave up. So that clearly was frustration. She was drinking on her own with a cup at that time. Then they decided the Nazanan didn't work. Now we're going to try on Respiridol. So not knowing anything, or not knowing as much as we should have, Respiridol seemed to be something that would possibly work, so they put her on Respiridol. Well, 24 hours after that, she was snowed under again. She wasn't able to drink. The day before, she was drinking with a cup. That day, she was slamming a cup into her mouth. The next day, she didn't know what she was doing. She stopped eating prawns, which was a huge marker for us. I went out and got her prawn dinner every night. She hated the hospital food, so every night I went out and got her prawns, and we measured her progress for the week by how many prawns she had. So she had 62 prawns. It was a good week. If she had 50 prawns, it wasn't such a good week. She went down to 30 prawns, then she went down to no prawns, and at that time, we knew we were in trouble. She was non-responsive, and she didn't recognize her family. March 22nd, she wasn't eating. I said she was starving to death. She wasn't able to eat. The medication was stopping her from eating. She was unable to walk her toilet. She had a complete decline in all her abilities. I was trying to communicate with her doctor. I would phone him and leave messages. He wouldn't respond. So then I started faxing him. I called his office and I said, can you please respond to the questions in the fax? I had told him immediately after the Respiridol the next day that it wasn't going to work when I saw the reaction to it. The response from the hospital is, we cannot reply to a fax. You have to make an appointment and we can't bill you with a fax. My mother died April 2nd. There was no consistency in caregivers. That led to incorrect assumptions and improper treatment. I had to explain every day that she came from her home, not a home. that she was a individual who walked and talked when she came into the hospital. She went to the washroom when she came in, and when she needed to use the bathroom, the response from the caregiver was, she has a brief. I said, my mother goes to the bathroom. She does not go in a brief. She wasn't given any exercise or walks through the day. The caregivers would spend all their time on iPhones instead of focusing on her patient's needs. I had to continually interrupt them so that they would take a peek at her and help her. And in one instance, the nurse who was to give her the medication for the bowel movements was literally shoved it in her mouth, and my mother pulled back. And she wouldn't take it. So I had said to the nurse, well, I'll give it to her. Just get her ready for bed, and when she's finished, I'll give it to her. Well, when it came back in the room, she'd thrown the medication away, and I said, where's the medication? And she said, well, that's all you're going to get into someone like her. 2 days later, she had the impacted bowels. So I'm here to ask, how can you combat the continual staffing changes? How can you combat the lack of time spent with patients? How do you change the attitude towards aging patients? One of the caregivers was looking out the window, and there was a mobile van that used to transport the patients from the nursing homes into the hospital, and she looked out and she goes, here comes another van. And I said, oh, what's that? And she said, she sighed and said, they're always coming in here. She said, I don't know why we're spending all this time and money. We should be focusing on young people who contribute to society. This was a woman who was looking after my mother. Prescribing medication that does not help the patient and makes it easier to control them. And I had mentioned to you I had a hallelujah moment when you had spoken about a couple things. The Haldol, for whatever reason she was on it, did nothing for her agitation, and it did not restrain her. And how do you prevent unnecessary deaths in elderly patients? Lloyd's story is my husband's father went into the hospital 2 weeks after my mom passed away, and he's 84 years old. He'd fallen and broke his hip. And after waiting for 36 hours for the operation, the nurse came in and said that she had the medication for him. It was morphine for pain, and then the Respiridol for his agitation if he should need it. And my husband shut that down immediately. He was not going to get Respiridol. This is my mom on her birthday with the kids that loved her. So I believe, based on everything I saw and everything I read, her seemingly unnecessary and catastrophic decline was caused by an insensitive or irresponsible use of drugs. We later found out that Seroquel was given at some point, but I'm not sure the dates on that, so that was something else that was added into the mix over the course of the 3 months she was in the hospital. I was there often for 16 hours a day. I observed her behavior and took detailed notes, and I saw the decline in food intake, the inability to rally as different drugs were given and taken away. And while there was obvious drug issues underlying all of this, I observed an experience what only can be described as a derelict lack of focus on individual care for my mother, and I can only assume this is common. Thank you.
There's reverberation, so it may sound kind of funny. I'm hearing myself in duplicate. I'm not sure, Chris, which slide set you have.
They're from yesterday.
Okay, all right, and you're going to control the slides for me?
Yes.
Okay, and is anybody introducing me?
Hi, Carol. Welcome. Hi, it's Sue Bedford here. We're looking forward to your presentation.
Okay, hi, Sue.
Hi.
So I guess I'll introduce myself. My name is Carol Ward. I'm a geriatric psychiatrist, and I work at Hillside Center. And that's an acute tertiary mental health hospital here in IHA. But I also do outreach work to long-term care, residential care. And that actually has been my passion for most of my career. So I hope that the next presentation will help us understand that we are trying to make a cultural shift and how we provide care for frail elders. The focus of my talk is on residential care, but hopefully some of these lessons will translate to acute care so that the previous speaker's experience isn't repeated. Can you switch the slide, Chris? So I was asked to talk about the understanding of the use of antipsychotics in geriatric psychiatry, or geriatric psychiatry practice, including their role in the treatment of specific behavioral and psychological symptoms of dementia. Sorry, I'm getting a lot of feedback from your end. I'm going to highlight the IHA provincial and residential care initiatives for reducing inappropriate prescription of antipsychotics. And I was also asked to talk a bit about antipsychotics and the Beers Update 2012, or the Beers criteria. Next. Next slide.
There we go.
I can't. Okay. So one of the things that I get asked to address a lot in residential care when providing outreach consultation liaison is the issue of aggression. Now, I'm not sure if you have talked about some of the safety issues, workplace health and safety initiatives that have been going on in the province during this conference. But obviously, this whole issue with respect to, in particular, dementia and related behavioral and psychological symptoms is a serious one, and it's a complex one, affecting both caregivers, staff, and residents of long-term care. Next slide, please. But we are also very much aware, and the previous presenter highlighted the challenges, the risks, and the dangers of being given medication that may not be indicated in frail elders, or where frail elders are very sensitive to side effects of medication. And this has been quite in the public eye, in the past year. Next slide. I would encourage people to look at this report from the Mental Health Commission of Canada, and it's the Mental Health Commission of Canada Seniors Guidelines. It's an excellent document that highlights some of these issues. It's an excellent resource for planning. It highlights benchmarks. And it also really reinforces the importance of outreach consultation from mental health experts to residential care to help with this whole issue. Because unfortunately, age does not mean that you aren't without mental health challenges, and frequently without more than one. So unfortunately, people who, for example, have suffered from major depression in early life can also get Alzheimer's disease. And then you're dealing with a very complex problem. Next slide. With respect to antipsychotic use, I think it's important to identify from my practice perspective and how we initiate drugs and for what and for when, that we're clear on their role. And in psychiatry and treatment of mental health disorders, antipsychotics are used to treat, if necessary, disorders like schizophrenia and related psychotic disorders, bipolar disorder as a mood stabilizer, so not necessarily for psychosis. In the treatment of major depression, both psychotic forms of major depression and major depression without psychosis, particularly in cases that are treatment refractory. And quetiapine, which is an atypical antipsychotic, is labeled for the treatment of major depression. So we are learning that, in fact, we should be thinking about some of these drugs as drugs with antipsychotic properties because they are used for more than one reason. Next slide, please. In dementia, and specifically the behavioral and psychological symptoms of dementia, the target symptoms for antipsychotics, if required, are the psychotic symptoms, delusions and hallucinations, but also severe aggression, manic-like behavior, and sometimes sexually inappropriate behavior. Next slide. They are also the gold standard drug treatment for delirium. Next slide. The reality is, though, in residential care, as I said previously, that the incidence and prevalence of mental health problems is quite significant. And if you look at how it kind of breaks down, this is a paper by Dr. Dallas Seitz, who is a Canadian expert in BPSD. You can see that in residential care, on average, about 58% of residents will have some sort of dementia. The most common type of dementia is Alzheimer's, but also Alzheimer's mixed vascular is probably right up there. All of the dementias can have associated behavioral and psychological symptoms of dementia, and those can happen with great regularity. In fact, probably up to 90% of people with a diagnosed dementia will have at least one behavioral challenge throughout the course of their dementia. Major depressive disorder is prevalent in residential care, and up to 25% in some studies, 10% on average. Clinically significant depressive symptoms are also prevalent. Unfortunately, the other mental health disorders like anxiety disorders, schizophrenia, bipolar have not been well counted in residential care, and those are just some estimates of prevalence. Next slide. Just to be clear what we're talking about with respect to behavioral and psychological symptoms of dementia, this is a definition that comes from the International Psychogeriatric Association back in the 90s. It's a consensus definition, which is one of the reasons why I like it. And it describes BPSD as symptoms of disturbed perception, thought, content, mood, or behavior that frequently occur in patients with dementia. But other terms are used in the literature, such as neuropsychiatric symptoms or responsive behaviors. Next slide. I think it's important to at least look at the list of some of the antipsychotics that are available. They're broken down into two classes. One class is called atypical, and the older drugs are called traditional, of which haloperidol fits under that class. You can see that there are many atypical antipsychotics on the market. The most commonly used ones in residential care would probably be risperidone, olanzapine, and quetiapine, possibly followed by clozapine. They're all different in their side effect profile. Some are more sedating, some have no sedation at all, some have different impacts on glucose metabolism and lipids. So they're actually all quite unique. Next slide. However, there are significant safety concerns. And this is a list, and it's not an inclusive list of some of the challenges that may occur when somebody is prescribed an antipsychotic. In Canada and the United States, there's black box warnings on the use of antipsychotics because of the slight increased risk of mortality and cerebrovascular adverse events. But not every single antipsychotic will necessarily present with all of those potential problems. Next slide, please. I was asked to comment a little bit about the Beers criteria. And the Beers criteria is a list that's been around for quite a while now. And it's a list of potentially inappropriate medications in older adults. And you can find it at that website that's listed at thereamericangeriatrics.org. I think it's important to remember, though, that the Beers criteria isn't an absolute list. It is a source of safety information. It's a good resource to look at side effect profiles of drugs that you might be interested in prescribing. But it doesn't dictate prescribing, and you still have to make clinical decisions that are informed, because unfortunately there aren't sometimes safer options from a side effect profile perspective for a given medical problem. In the Beers criteria, if you look at it, it lists antipsychotics, and it has this quote: to avoid the use for behavioral problems of dementia unless non-pharmacological options have failed and the patient is a threat to self or others. Next slide. Excellent resources in Canada are the Canadian Coalition for Seniors Mental Health. That's the first website that I've listed there. They've got excellent resources for depression, delirium, mental health issues in long-term care, including drug advice with respect to BPSD. The other source of guidelines is the Canadian Consensus Conference on Dementia, the CCCDTD4, and that was released earlier this year. Both of those sites identify the role of atypical antipsychotics for BPSD this way. And in particular, the use of risperidone, olanzapine, and aripiprazole have the best supported research for significant agitation, psychosis, or aggression. Next slide. In fact, risperidone is the only atypical antipsychotic officially labeled by the Health Protection Branch in Canada. And if you read how they've defined its use, severe dementia, short-term management of inappropriate behavior due to aggression and or psychosis. So all are essentially consistent. Next slide. However, we know and we're concerned with overuse, and these are just some statistics that are available. The Canadian average is very similar to the average in the United States for overall use of antipsychotics in residential care at 33%. British Columbia in one document 36%, and in IHA almost 40%. The issue with respect to reading prevalence percentages is to always try to understand what's being counted, how it was counted, and definitions that are used. I know that in IHA, when they were counting antipsychotics, they actually included also anticonvulsants. So the numbers, you have to understand where the numbers come from. Next slide. But it's a concern, and it's been a concern in IHA. I think we've been sort of working on this since 2008. In 2010, though, we convened a group, the Antipsychotic Working Group for Residential Care, and came up with a strategy to try to move forward on decreasing the use of antipsychotics inappropriately. And it kind of consists of 4 parts. The first is the BPSD algorithm, and I'll talk a little bit more about that in a minute. We also developed a behavioral SBAR, which is a communication tool so that a nurse could, in a summary way, communicate with a family practitioner in an acute situation to help guide the appropriate management strategies for BPSD and dementia. We're still working on our pre-printed order project for the initiation, titration, tapering, and discontinuation of antipsychotics. This is a more lengthy process. Every time I look at the documents, I see a typo or something's not right, so we're trying to get them as refined as possible. Once we have all of that in place, our residential care group will come out with a clinical practice standard and procedure and an implementation process for distributing this throughout residential care in IHA. Next slide. However, our major initiatives to date has been the development of our BPSD algorithm, which is located currently on the interiorhealth.ca website. And we wanted to develop something that could be easily accessible by staff, that you could actually bring to a smartphone so that physicians, I was hoping that physicians could actually bookmark it to their smartphone and take it with them into residential care so that they'd have an easily accessible tool to help with respect to the assessment of these challenges so that you don't automatically jump to medication prescription when it's not warranted. And so we went forward and developed the BPSD algorithm. which really, next slide, is a strategy of assessment. Now, this may not project well at your end, and you can go to www.interiorhealth.ca and type BPSD algorithm in the search bar and bring it up so that you can look at it more closely. But it is a strategy for identifying the target behaviors, determining the acute.
Oh, hung up.
Sorry about that. I think that we're going to have to just move on and continue with the next speaker. So the next person to present is Andrea is going to go next.
Great, thank you. My name is Andrea Felsman. I'm a clinical practice leader with the residential care team in Vancouver for Vancouver Coastal Health. And I'm going to be talking about the use of antipsychotics. Just as Dr. Ward was talking about the algorithm, that's where I was going to pick up and talk about our implementation strategies. So I might highlight just a little bit more because I know that what she was going to share in terms of the work that we're doing in partnership that we're doing with the ministry. So I'm going to be talking about the implementation of that and discussing metrics and quality improvement measures that we can use to determine and assess for how our quality improvement projects are doing, to look at. Dr. Ward, are you there?
I am.
Oh, hello.
Not sure what happened.
Hi, Carol. We're in a bit of a crunch for time here, so we're going to let Andrea continue. She's just started her presentation while we're having technical difficulties.
Okay, sure.
So I wanted just to really quickly highlight the prevalence of the use of antipsychotic and dementia, the correlation in dementia in terms of research trending. This is a really quick snapshot of a Google Scholar search trending from between 2000 and 2012. You can see in about 2000 to 2002, there were about 4,800 hits on the Google Scholar search engine, which is an academic peer-reviewed scholar engine for looking at citations in our peer-reviewed articles on dementia and antipsychotics. That jumped up to about 14,000 in 10 years. So it's a very prevalent issue and topic. And congratulations to the SFU committee for bringing this very somewhat contentious and difficult conversation to the residential table. So a lot of people are talking about dementia and antipsychotics, particularly in residential care. There was a webinar in March looking at online module education that the Winnipeg Regional Health Authority is doing, and they presented at the Canadian Foundation for Healthcare Improvement. It's a fantastic online module that looks at dementia, brain behavior pieces, and antipsychotic usage. And I'm going to be showing you a slide of the outcome at one particular facility who has used this education module and how they've impacted the prescription, the use of antipsychotics in their facility. This last month, Hartford Institute for Geriatric Nursing had a presentation on reducing antipsychotic medication in older adults in residential care. The video conference on the Institute for Healthcare Improvement had a fantastic journal presentation from 3 physicians, and this was a paper that was released on the Journal of American Medical Association. And all of these are just within the last 3 and 4 months. And so it just highlights the fact that this is a fantastic time to be able to talk about the use of antipsychotics in residential care. And we're talking about it here in BC. As I mentioned, Dr. Ward was just getting into talking about the best practice guideline that has been released on BPSD in dementia, in residential care. It's been a fantastic collaborative effort with all 5 health authorities, as well as BC Care Providers Association, Patient Safety Quality Councils, non-denominational health associations, and it's just been a fantastic collaboration to be able to come together and look at the use of non-pharmacological interventions as a first-line management for behaviors in persons with dementia in residential care. What Dr. Ward was just getting into was talking about the philosophy about understanding behaviors and understanding the meaning behind behaviors rather than sedating the behaviors, controlling the behaviors, mitigating and stopping behaviors. It's really coming out of philosophy of trying to understand the meaning behind behaviors. A second outcome with this practice guideline is reducing the inappropriate use of medication, the antipsychotic in persons with dementia behaviors. When I was providing consultation a few years ago, I went to a facility to do consultation with an elderly resident with dementia who wandered and was just kind of restless, and the staff had really difficult time in trying to figure out what his needs were, and so I went through a whole consultation process, looked at the MAR, and I found in 1 month 29 PRN antipsychotic medication administered for wandering and settling behaviors. Did a little bit of education on restraint, proper use of antipsychotic, and non-pharmacological behavioral management. I went back then a month later, and the subsequent month, those PRN meds were from 29 a month down to 3 a month. And so I think there's great emphasis in this clinical guideline around reducing the inappropriate use of antipsychotic medication. And that's just not on the physician part. That's also educating the nurses and educating the staff on how to provide care, so we're not calling the physician at 11 o'clock at night and asking for medications over the phone. And the last place is the process for tapering antipsychotic medication. So identifying up front what are the targeted symptoms that we are looking at, and when do we no longer need antipsychotic medication? When is it appropriate to start tapering that? And I think that goal needs to be up front with why is it that we're starting the medication to begin with. I received a call a couple of years ago from a pharmacist talking about her population in a facility and saying, our resident population in this particular facility, they're mostly the traditional language, extended care. They're requiring total care for their ADLs. And she says, we've got 50% of our residents in our facility today are on antipsychotic medication. And so what is the role of the nurse to partner with physicians and pharmacists to look at tapering? There needs to be as intensive process behind starting it as it is coming off of medications. So implementation in Vancouver Coastal, the guideline as it is has been shared with the Regional Residential Quality Practice Council. I'm the chair, so I made sure that happened. We've also shared it with the affiliate and contracted site, but as Dr. Carol Ward was just mentioning, the algorithm working group has continued with bi-weekly meetings since about January to come to consensus as a province around what are tools and practices around identifying non-pharmacological management items first for management of behaviors, and second, what are the processes to look at assessment tools and interventions so that we can provide and offer family physicians and psychiatrists background information so that they can make their clinical decision making around the assessment around the appropriate use of medication. So besides having a quality improvement implementation perspective, in my mind, a quality improvement project such as endeavoring to implement this guideline is only as effective as insofar as you can demonstrate an improvement. And to demonstrate an improvement in the use of antipsychotic medication, you've got to have metrics. And for those of you who don't get a real high on metrics and outcomes in RIMDS, I'm so sorry. I'll whiz through this, but I live and breathe this stuff. So it's a little pithy quote. If you can't measure it, it doesn't exist. I'm not quite that black and white, but it does say if you're going to do an implementation project like implementing an antipsychotic BPSD guideline in residential care, we got to have metrics. And we have to have metrics up front before we start a project to implement this clinical guideline. So how are we doing on time? 5 minutes? Couple minutes. What are we saying in Canada about metrics for antipsychotic usage of medication? Has anyone seen this report? Oh, that's discouraging. Okay, this is a fantastic report looking at residential quality indicators for residential care, and one of the highlighted of the 8 quality indicators that this report refers to is the use of antipsychotics. And this is a look at Canadian perspective on antipsychotic use in residential care, and the QI specifically, this is for medication prescription of antipsychotic for those without a diagnosis of psychosis. So it's the definition from CAI. And the mean rate for Canada is around 32%, and you can see here in BC that our median is a little bit above that, and we've got quite a large range over our use of antipsychotics without a diagnosis of schizophrenia. In BC, what are we saying about metrics? A couple of years ago, the ministry released a document. The data source for this is PharmaNet, and there was about a 12% increase in the use of medication between 2000 and 2010. And so these metrics are giving us an understanding of where it is we are and where we need to go to. So any robust implementation, Christine is going to talk about implementation in the sex, I'm not going to steal her wind, but any robust implementation needs to have a process for measuring change. How do we know that we've made a difference? And so are 3 areas to measure change in terms of implementing a guideline to reduce the inappropriate use of medication and increase non-pharmacological meds includes looking at CAPS. CAPS are at a resident level, that's part of the MDS assessment that is mandated to be done quarterly. You can look at trending on how a resident is doing with CAPS and how a facility is doing with CAPS, which is looking at how many of your residents are triggering having experiences with aggressive behavior. Another look at, another output from RIMDS for measuring change is using outcome scales, the aggressive behavior scale. And you can look at that at the resident level, and you can look at that at the facility level. This is an example of a facility level look at the outcome scale, the aggressive behavior scale. And these are 4 facilities that are demonstrating their differences in how frequent behaviors are being present in residential care. We need metrics like this, that when you implement a guideline, you have something to benchmark and say, have we made a difference? Have we budged the needle in reducing behaviors and reducing the inappropriate use of antipsychotic medication? This is a quality indicator that can look at the facility level as to whether or not behavior symptoms have worsened, whether behavior symptoms have increased. And this is the quality indicator that I mentioned earlier, is the percent of residents on antipsychotic medication without a diagnosis of psychosis. The reason why I'm thrilled about this last QI, which comes from CIHI, is that you can see that this particular facility called Churchill in Manitoba, which I mentioned 3.5 minutes ago, had the online module for antipsychotic brain behavior and PIECES education. They implemented this module, and within 1 year, 4 quarters, they saw a 12% reduction in antipsychotic medication with no increase in physical restraint. So we need to have data, we need to have measures in order to demonstrate whether or not a quality improvement project like this is showing change. The last source of metrics is there are some pharmacists, and we've got one facility represented here, where the pharmacists have access to software and data that they can actually, at a resident and facility level, give you trending data on the use of antipsychotic medication in your facility, including PRN, its relationship to the use of SSRIs and so on. So that's the end of my 8.5 minute spiel on the use of metrics when we're looking at implementing this Ministry of Health clinical guideline on antipsychotic and BPSD. Thank you.
Can't see around the laptop. That's one of the perils of being short. But thank you for having me. My name is Christina Kraus. I'm the Executive Director with the BC Patient Safety and Quality Council. We are a government organization that works in partnerships with the health authorities, with the ministry, with primary care, basically all of the health services in the province. We have a mandate to improve the quality of care right across the continuum. So we've done a lot of work in different areas of care. And really, our primary role is to help sort of accelerate improvement in the system so that sites or facilities or providers who are wanting to improve the quality of care will do so faster than if they'd been on their own. So we sort of see ourselves as a facilitating, supporting organization that has quite a bit of experience around quality improvement, change management, and how do you bring in new practice to improve quality of care. And so what I wanted to talk to you about today is an initiative that we're launching in June called CLEAR, which is a call for less antipsychotics in residential care. And so I'll just spend a few minutes sort of talking to you about it. And I think really Andrea's presentation and Carol's presentation and also Leslie's presentation were a fantastic primer to sort of call you to action and to invite you to join us on this journey to actually change, I think, some of the stories that we're hearing around what's happening in this province around the use of antipsychotics. We actually didn't do this alone. We did it with a large number of people. We had almost 100 individuals come together in January, and we actually asked the question, what could we achieve if we worked together collectively around this issue around reducing the inappropriate use of antipsychotics? What opportunity do we have in this province? And we used that day to actually define this initiative to talk about how we would provide support, what we felt we could achieve by working together, and who the key stakeholders needed to be involved. So we had a broad spectrum of individuals. We had patients in the room, we had academic, we had Ministry of Health, we had a lot of representation from medical directors and directors of care at various care facilities across the province. We had representation from Shared Care Committee. There's a fantastic initiative around polypharmacy that we'll be working very closely with, as well as the Ministry of Health's initiative called Clinical Care Management. There's a focus on medication reconciliation in residential care. So what we're trying to do is to bring all of these together. And so we had all of the key stakeholders in the room to help us define what the opportunity could be. And we went through a visioning exercise to define what we believe we could achieve by working together. And so our vision is that through CLEAR, we will enhance the dignity of seniors in residential care by providing support to residential facilities across this province to work collaboratively and with partners to deliver individualized assessments, so care plans, and evidence-based care, which will lead to a reduction in the use of antipsychotic medications. So it's absolutely what I think both Carol and Andrea are talking about. It's around that inappropriate use. We know that in some situations there is a need for antipsychotic medications, but we know that, and I think especially through Leslie's story, there are situations where they are being used that we don't want them to be. So how can we get there? And our role is to help you, to support you to get there and to be successful in that reduction. This is a voluntary initiative, so it's for any care centre in this province that is interested in working on this issue. We are inviting you to join us. It is voluntary, it's not mandated, and it's really some enhanced support for you around the change process, absolutely in line with the new ministry guidelines around BPSD, around antipsychotic use. So it's about taking that evidence and putting it into practice, aligning with the pieces, the new behavioral management opportunity that we have in this province. And so we're not trying to create new work. We're trying to support you to be successful in the work that you're going to be undertaking. We also know that this is a great opportunity to build some of the capability and capacity for quality improvement work in residential care centres, so that if there are other issues that you want to take on, we can build up that skill set around quality improvement skills that you can use in other areas. So there's a ton of activity going on in this province around medication use in residential care, and one of our primary purposes is to try and make sense of that and better coordinate it and bring it together, so it's around one care process for a resident in our facility, and how do we look at all of these opportunities and supports available to us, whether it's the polypharmacy initiative, so looking at the number of medications that residents are on and trying to just actually pull that number down, because there's solid evidence that says the number of medications people are on does make a difference. The clinical care management, I've talked about the medication reconciliation. There's another initiative that's actually focusing on acute care, but I think we can actually work a bit upstream into residential, called 48-6. And it focuses, I think, a lot around what we heard in Leslie's mom's journey around mobility, nutrition, medication use. So there's an opportunity there as well. And we know the ministry has both their seniors action plan and the dementia action plan, and then the work around the BPSD guideline implementation group. So all of these different initiatives that we know are sort of hitting all of you working in the care facilities separately, we want to kind of bring those together. And so that's one of the goals as well, is to kind of make sense of all of the actions happening in the province around medication use. So we have a very lofty aim. This actually is part of our change management methodology, and so our goal is to achieve a 50% reduction overall in the province collectively from baseline in the inappropriate use of antipsychotics through evidence-based management for the BPSD for seniors living in residential care by next December 31st, 2014. And so that's a collective aim. We have seen examples where people have achieved this. We know it's possible. In the United Kingdom, in 1 year, they had a 50% reduction across their country in the use of antipsychotics, just in the number. We've seen the Winnipeg example. We have some fantastic examples in our own province, some great programs happening in interior health around the behavioral management, some other facilities as well. So we know this is possible. We know we can achieve it. And so what our hope is that by working together, we can actually make a big difference right across this province. So our goals are to improve the dignity for seniors living in residential care through this initiative, to enhance those linkages around those existing initiatives that I spoke about, and to build that capability around quality improvement in residential care. We are establishing what we're calling a partnership alliance. We know there's a number of committed organizations and groups that are very keen to work on this issue. So we'd like to bring them together through a partnership alliance that will include Ministry of Health, the health authorities, the Alzheimer's Society, the Care Providers Association, the nominational care providers. So there's all sorts of groups that we're going to be pulling together to help provide overall guidance. And we can also hopefully find and seek opportunities to work together and to make use of the resources that we already have within the system. We also have a clinical advisory group that's been working very hard looking at some of the clinical issues, but also looking at the measures that we want to look at. This group will help provide guidance to the initiative around resources and tools and information that they can use, and really to also help support those care centers that are working in the system. So I wanted to just show you who's part of this group. We've got representation from various facilities, health authorities. We have we have Betty Murray from the Patient Voices Network, as well as a pharmacist, Chris Hunter, from up the north. So we have a fantastic group, I think, of individuals who are highly, highly passionate and committed about this work, and are providing some leadership for us around it. The Quality Council, which is the organization that I'm a part of, is providing sort of the secretariat support to both of those groups, and providing a lot of the improvement coaching. So we will have improvement advisors that are available to provide on-site support at care facilities if you don't have existing resources from your health authority, or if you're not part of a health authority, if you don't have that relationship. We really want to help build that capability so that the leadership happens from within the facility. So not a sort of a consulting role, but really a support and training role. We'll be having a big kickoff event in the fall. We will be looking at regional workshops, site visits. We'll also have faculty will be available for support. We're looking at various strategies. We've been talking with the folks on the clinical algorithm. How can we make that interactive and web-based, whether it be through an app or on a website? So we're looking at how can we best support you to be successful in this initiative, and that's really the intent behind this. So there's a number of ways to be involved. You can enroll a team, sort of what we're calling an action and improvement team. These teams will sign up. They'll need support from their administrative leadership in their facility, but they will receive improvement coaching and support. There'll be both in-person and online webinars for learning opportunities. We will be asking you to collect data for improvement. I think Andrea made the best case for that, so I don't need to go into that one. And we really want to have these multidisciplinary teams happening who are highly active and working towards making changes. We also know that some facilities might be very interested in this but don't have capacity at this time to have a team, so we will have an option for people to be organizational partners so they can participate at least in the online opportunities for learning, as well as access to the information sources. And anybody, any individual who's interested in this, we also invite them to join so that they can receive the information and also participate in learning as well. So there's a number of different choices. We wanted to make choice available so you can do what fits best for you in your context and what your needs are. We have some great principles that the group on January put together around how we're going to work together. It's all about supporting each other to succeed so that nobody's working in isolation on this issue. The more we can share and learn, the faster we can actually make the changes happen. And so that's really the principles about how we work together around that sharing, evidence-based practice. So this is all based on those guidelines that are in place. So we are focusing on 4 primary areas. One around the medication review. That's where I think medication reconciliation, partnerships with the pharmacists in the communities, the polypharmacy initiative. There's all those initiatives around medications. We know that care planning. Appropriateness is something that we've had a lot of discussion about. What does inappropriate actually mean? Well, it's one of those dimensions of quality along with acceptability of care, safety of care, effective care, and access. But appropriateness is care that is individualized and based on best practice. So anything that is not individualized based on that patient, based on best practice, is inappropriate. That's what we're trying to take away here. So it's really focused around that. So we know care planning is a big part of that. There's also a ton of data that's now coming out around culture, teamwork, communication, linked to clinical outcomes. So that data now exists and it's been replicated over and over again. So we know that working on the culture in your facilities is going to help you get better outcomes for your residents. So we're going to have some work around culture and teamwork and communication, and then also aligning with the education around the behavior management, sort of those non-pharmacological supports, pieces being one key strategy around that. So those are the 4 sort of focus areas. We will be asking for data to be collected. We're looking at the RAI and the MAR as opportunities to actually pull data, and there will be a few measures that we will ask people to share with us so we can document our time and our progress, our success and our progress towards our aim. And then there will be some other measures that you may want to collect just within your own facility to help you along your journey for that quality improvement process. So we'll support you on that way as well. So our call to action is coming out in June, so we are going to be sending it out to every care facility in the province. We'll also be sending it out first to some of the leadership groups that exist so they can send it out to their own facilities ahead of time as well. We do have information calls. These are 1-hour webinars. There's 3 of them, so you can pick the one that fits best for you in June 18th, 25th, and the 9th. We just changed our team enrollment deadline yesterday afternoon, so we're going to move it up to July, and then we'll have an in-person meeting kickoff event in October, and then we'll be moving to more regional-based support. We know that travel is a big issue, so we didn't want an initiative that required a whole bunch of provincial meetings, so we're going to move out and come to you. So I really, really hope you'll join us. If you want any more information, please email us or go to our website, which is the bcpsqc.ca, and we'd be happy to talk with you. So thank you.
Thank you very much. Those were, I think, all work together really well to paint a picture of the issues, of the challenges we have and where we're going. We have about 5 minutes for questions, and I'd invite you to come to a microphone so that everybody can hear you and we can record your question and the answers as well.
Hi, just an administrative question. There were a lot of useful information on the presentations, but they went by very quickly. Will the conference organizers be providing copies of the presentations and the handouts to attendees?
Yes, we announced yesterday the screen videotapes and the PowerPoint presentations will also be available.
Wonderful. Thank you very much. My hand is very sore from writing. And I have one other question, and really it can go to anyone. There was a lot of information about different types of dementia and so forth, and of course we're talking a lot about antipsychotic medications and other medications with adverse effects. But I didn't hear anything about drug-induced dementia, and I'm sure those of you in the field will know that that's a growing term, that there is, that people are being diagnosed with dementia when the cause is solely antipsychotic and other medications, caused by antipsychotic drugs and other medications. So can someone speak to that issue about whether anyone in the Canadian healthcare system recognizes the label that's growing, that's called drug-induced dementia?
Carol, can you... Hi, welcome back. Can you speak to that question? Carol, you're on mute.
Sorry. When physicians approach individuals who come with complaints of memory difficulties, they are trained to look for reversible causes of memory impairment, and drugs are the first things that you should evaluate. So it is part of our practice to make that assessment.
Okay, thank you.
I can actually speak to that as well.
All right, thanks.
When my mother was diagnosed with dementia, she was on tramadol, morphine, and OxyContin. And we, the family, said she absolutely does not have dementia. She didn't have dementia prior to this. We believe it is the a result of the drugs, and those were the 3 drugs she was on when she was diagnosed.
Okay, thank you. I have a supplemental question, actually, for your family situation, with your mother being given Haldol when she went into the hospital for a cortisone treatment. You said sometime later, I'm not sure if this was days or weeks, the doctor was contacted, and I presume this was her GP, and brought in, and he was horrified that she was being given Haldol, and he stopped it immediately.
He knew she was on it. He was just horrified at what he saw. When he
I
saw
see.
her
So
condition.
was he the one who actually...
I'm not quite sure. I'm still trying to find out.
So you don't know who authorized the use
no,
of
I'm not
Haldol?
Sure. It could have been the psychiatrist in the hospital, or it could have just been an order that the nurse had to be able to give. They're giving it out in that hospital like candy. Every second person in there is getting it. That's an exaggeration. I'm sorry, but I kept hearing the Haldol, the Haldol, the Haldol. So it's not an uncommon drug that they're giving there. And she was on it from December 25th until February 15th, without our knowledge, 3 times a day.
3 times a day, from December 25th to February 15th?
No,
Or
to January 15th.
January 15th, okay. All right, thank you.
Hi, I don't really have a question, but I wanted to speak about what happened with Leslie's mother. My father ended up in Burnaby General Hospital with Alzheimer's. He was there for roughly 4 months, and in that time he was given over 100 doses of Haldol. We got the drug records from the hospital. When he entered the hospital, he had the ability to walk, to talk, to feed himself, to go to the bathroom. He lost his ability to walk. He couldn't feed himself. He was in a brief. We had the exact same experience that Leslie had at Burnaby General, rotating doctors that had no knowledge of what he was like when he walked into the hospital. Nurses, everybody said he was aggressive. Nobody would understand that he was afraid. And we kept saying, he's afraid, he's scared, he doesn't know who you are, he doesn't know where he is. Everybody kept saying, oh no, we need to manage him. It was all about managing him. It wasn't until he ended up in acute care that we found a geriatric specialist that stopped the drugs. She finally said, yes, we will stop all the drugs. He was on Haldol, he was on Risperidol, he was on Trazodone. At one point, he was overdosed with Haldol so severely we couldn't wake him up for 36 hours. We had to spend the night at the hospital. And we ended up going exactly like Leslie did. We went to the hospital every single day, from mid-morning till he went to bed at night, to make sure he was being fed, make sure he was being cleaned. Sometimes he would lay, one day I walked in the hospital, he was laying in a piss-soaked bed, and it was 11 o'clock in the morning, and he was soaked in piss. And the nurse ran over to me and said, I didn't know you were coming. We were, every day we fought at the hospital with what was happening to our father. When he was overdosed severely, when we couldn't wake him up, I asked, what were you giving him? What happened? And the nurse said to me, he got out of bed, so I gave him an extra dose of medication. Finally, he ended up getting they stopped the drugs. He ended up getting C. difficile. Twice he fought it off. He lost an enormous amount of weight. He's in a care home now, and I can't say, it's a wonderful care home. He's only taking Tylenol. There's no aggression, which we always argued. He was never aggressive. He's lost his ability to walk because of being in the hospital, and it's made an extremely difficult for the caregivers and for us and for him, because now he's in a brief all the time. And I just wonder, I think is the care home he's in, they won't drug him. They don't believe in that. They know how to manage it when he's afraid or when he's appears to be aggressive. They know his personality and they can calm him down in various ways. He can be distracted very easily, but what do you do in the hospital when an Alzheimer's patient ends up in the hospital and they're immediately drugged? When we walked into the hospital, he was tied into bed, naked except for a diaper, and drugged out of his mind. And we never could find out who authorized this, and they refused to stop the drugging. They kept saying, oh, we need to find the proper dose. We kept saying he's not aggressive and he does not need to be drugged. And it wasn't until he was in the acute care ward that the geriatric specialist said, okay, we'll stop giving him the drugs. But our experience was exactly like Leslie's, and we feel that our father would have died in that hospital without us being there all the time, like watching what was happening and watching what the nurses were and weren't doing. So I just wonder what you can do in the hospital situation. I know that the care home he's in now is fantastic. They're really taking good care of him. But it's really impacted his health, what happened in that hospital situation. So.
Thank you very much. We've heard a lot this morning from heartbreaking to hopeful, and I think that the challenge some of the challenges that we've heard this morning and the opportunity to be engaged in a new and exciting initiatives are something that we can all put our efforts behind. I know there are lots of great care providers, great care facilities and caring staff in the residential care system, and there's also a lot of work to be done. And I thank you all for your thoughtful comments and for your presentations, and we look forward to continuing the dialogue with you in the future.
Oh, I guess I don't.
Okay.